Good day, everyone, and thank you for joining us. Our title is Women's Heart Health in Pakistan, Opportunities for Health Equity and Economic Growth, a critical examination of gender disparities in cardiovascular care and social health and economic implications, with strategic recommendations for national and global health policy reform. We will explore gender disparities in cardiovascular care, look at their wider impacts on society, and propose evidence-based policy reforms for improving both health outcomes and economic participation for women in Pakistan. The next slide, I'll be introducing my group members. This is a collaborative contribution from Sabiru Islam, Amir Hamza, Ajwal Smart Idowut, and Zunair Iftika. The next slide, which is the introduction. Cardiovascular disease, or CVD, is the leading cause of death among women worldwide, and Pakistan is no exception. Despite this, this is significantly underdiagnosed, undertreated, and underreported for women in Pakistan. According to Siddiqui et al. 2025, Pakistani women are 23 to 40% less likely than men to receive timely lipid tests or heart screenings. Cultural barriers, lack of gender-specific awareness, delayed diagnosis, and economic inaccessibility all contribute to this visible crisis, resulting in avoidable death and rising gender inequalities in healthcare access. The next slide, which is the background and significance. Why does this matter so much? Not just for health, but for national development. Let's look at the economics. In the US, researchers estimate $20 billion annually could be saved by closing the gender gap in CVD care. In Pakistan, where women already face limited workforce participation, the cost of untreated CVD may be even higher in terms of both lives and lost productivity. Yet, Pakistan's national health vision lacks any mention of female-focused cardiac screening protocols. Ignoring this issue undermines Pakistan's program on sustainability development goals, particularly SDG 3 on health and SDG 5 on gender equality. Now to the metrics and the impacts. Heart-related deaths are rising in women, especially in South Asian women. This shows many are not getting timely care. Women are less likely than men to get tested for cholesterol or start treatment early, which puts them at greater risk. The impact on daily life is also high, shown by increased DALYS, which stands for DALYs, or years lost to poor health. Rural women face more challenges in accessing care, leading to late diagnosis and treatment. On the paragraph, we see that CVD risk increases in age for both men and women, but women's risk rises sharply later in life. This suggests delays in detection. If not addressed, this leads to preventable deaths, higher healthcare costs, women leaving work early, and stress on families. This shows the urgent need for gender-sensitive health health strategies. Now, why we decided to embark on this topic, we chose this topic because it addresses a major yet neglected issue in both public health and gender rights. Heart disease is the number one killer of women in Pakistan, yet awareness remains dangerously low. Women often receive delayed diagnosis, less aggressive treatment, and inadequate preventive care. Pakistan still lacks a dedicated CVD strategy for women, despite clear trends and available global models. We saw this as an opportunity to highlight the need for targeted policy, research, and reforms. The next slide, which is the analytical approach. To examine this issue critically, we used a multi-method strategy. First, we conducted a comparative analysis with US benchmarks, especially data from the Women's Health Alliance. Then we reviewed screening mortality and risk factor data from WHO and Pakistan Ministry of Health. We modeled DALYs. DALYs stand for Disability Adjusted Life Years to estimate life years lost, and used a cost-benefit lens to estimate productivity gains. Finally, we aligned our recommendation with the WHO's Global Health Initiative, which promotes equitable healthcare systems. On this note, I'll be introducing my next colleague who will be talking on the historical context and the other slides. Hamza. Thank you.
Thank you so much. So my name is Amir Hamza, and my slide is historical context. So, first of all, historically, Pakistan's health system prioritized infections, disease, and maternal care. So, the non-communicable disease like CVD only entered policy discussions in the last 2 decades, and even then, women's heart health remained ignored. Most clinical trials in Pakistan historically excluded women, and today diagnostic guidelines remain male centered. This historical conclusions from research and planning has led to serious blind spots in how female CVD is detected and managed. So, the next slide is social context. In which social norms are another significant barriers. In many communities, women requires permissions from male guardians to seek medical help, and the financial dependence limits access to prevent testing like cholesterol check or ECGs. So awareness is very low. Many women and even doctors fail to recognize early cardiac symptoms in female, which are often atypical. Rural women face the most severe barriers, distance, lack of female doctors, and stigma around non-maternal illness. So the next slide is political context. In this slide, politically, the problem is structural. So the Pakistan's national vision 2016 to 2025 makes no mention of CVD in women. There are no national screening programs, no mandatory cardiac training in MBBS for women's symptoms, and no budget ring fence for females NCDs. So the policy implementations is further hampered by provincial autonomy, frequent political charge, and lack of continuity in health planning. So there is issues prevent the development of sustainable long-term reforms. So the next slide is VN for the future. Our goal is to help shape a gender sensitive national cardiac circular strategy. This includes gender responsive screening frameworks, increase rural access, mandatory training for healthcare provides on female specific symptoms. So, if implemented, these clouds save thousands of lives, increase female workforce productivity, aligns Pakistan's health system with C SDG 3 and SDG 5. So, the next slide is data sources and evidence used. We built our case on robust evidence base, including, first of all, peer reviewed medical journals. Second is the clinical research on sex differences and who policy documents and health targets. So the benchmark studies from the Women's Heart Alliance, and the last but not the least, local hospital and NGOs data, particularly from Karachi and Punjab. So these sources provide both global perspective and local context. So these are my slides, and the further slides explain my another group member, Sabirul Islam. So please, Sabirul Islam, can you explain?
Thank you, Amir Hamza. My name is Sabirul Islam and my student ID is 23107440 and on. And my first slide is theoretical framework. We use the McKinsey 7S model to assess system-wide weaknesses. Strategy: no policy specifically addresses women's CVT. Structure: no formal screening system for women. Systems: lack of data disaggregation by gender. Style: physician-centered care, women's concerns often dismissed. Staff: severe storage of female cardiologists. Skills: inadequate training on atypical female symptoms. Shared values: societal belief that heart disease is a man's problem. My next slide is evidence-based solutions. Here are our top policy recommendations, all backed by strong evidence. Firstly, create a national gender-focused screening policy. Now, 2025. Secondly, launch awareness campaigns. Only 19% of women know CVD is their top killer. Women's Heart Alliance 2024. Thirdly, integrate screening into maternal health programs. Siddiq 2025. Fourth, train doctors on female symptoms. Agarwal and Wood 2021. Last but not the least, include mental health support. Gafur 2025 report high depression among female heart patients. My next slide is data quality and application. Why does our data matter? First, it's peer reviewed and clinically grounded. Second, it combines global benchmarks with local realities. Third, it supports both short-term reforms and long-term economic gains. Our data helped measure prevalence and risk, life years lost dailies, economic impact, and policy gap in health planning. My next slide is analytical tools used. Our work relied on three key analytical tools. First, comparative study review to contrast Pakistan with global best practices. Second, McKinsey 7S to assess internal system misalignments. And the final is daily modeling to quantify the productivity and life loss associated with delayed diagnosis and care in women. These tools ensure our recommendations are scientifically sound, economically rational, and socially responsive. Thank you all, and the rest of the slide will be described by my another group member, Junaid Iftikhar.
Thank you, Sabirul Islam. My name is Zunaid Tahar, and I discuss our future options. So, we propose a phase implementation strategy, short-term reforms, 2 years, so the add gender-specific modules to medical training, and the other is build female health workers for outreach, and the launch pilot screening clinics in the major hospitals. And the other beside of the long-term reforms, 3 to 10 years, develop a national cardiology strategy for a woman, and the develop mobile clinics in remote areas. And the other besides use digital tools for monitoring and telehealth. So my next slide is conclusions. So the conclusion is cardiovascular disease in Pakistan's leading case of female majority. Women are the underdiagnosed, overly treated, and underrepresented in policy. Cultural, political, and institution barriers are deeply immersed. And the other besides, work reform is not only possible, so it is essential. With the right investment, we can save lives, reduce inequality, and the boost Pakistan's long-term development. So my next slide is risks and uncertainties. Of course, challenges exist. Budget constraints may affect implementations. Cultural resistance, especially in the rural areas, may slow adoptions. So the other side's health workforce shortage, especially female doctors, and remain a barrier. Future global health emergencies could divert funding and decide but the opportunities like telehealth, AI tools, and international sport maybe can sport might age these days. So my the other slide is final remarks. So the final remarks is the woman heard health in Pakistan. So that is the more is in health issues. It's a health rights issues. It's a very important for the final remarks women health in Pakistan because every of the peoples know the human rights issues. We urge health authorities, researchers, and the policy marker to act urge and diversity. So it's a very important to the final remarks. It is to time to move the beyond awareness and into the actionable change. So that the final remarks is that we urge health authorities, researchers, and the political marker to they act urgently and diversity. So thanks you for your attention, guys. And the other slide is there are just show in the all references in the show in the marks. Thank you.
Thank you so much,